Welcome again, everyone, to the third session of the 2023 COVID-19 Recovery for Routine Immunization Programs Fellowship. My name is Liz Colway, and I'm the Director of Community Building and Digital Engagement at Sabin. And I'm here today with several of my colleagues from the Sabin Vaccine Institute and the World Health Organization. So before we get started, I want to run through some Zoom webinar logistics with you all. I think you're probably familiar with these functions. But if not, again, we do encourage you to use the chat box throughout the session to introduce yourself and to provide your comments and experiences. If you do have a question for our session facilitators or the fellowship support team, we do kindly ask that you share it in the Q&A module, and that should appear in the remote panel of your Zoom webinar functions. You can also upvote questions in that Q&A module if you'd like them to be answered. Finally, at the end of the session, we'll have some time for some formal Q&A, and if we do have time, we'll allow you to raise your hand and voice over your question or comment. If the chat does get very distracting to you, you can actually go through and there's a downwards caret button that you can click on, and you can uncheck show chat previews, and then you won't be distracted during the presentation. Just a quick reminder that we are again recording the session, and we'll provide you the links to the recording and the slides tomorrow. And this communication will be sent to the email address that you registered with during the application process. We'll also upload all of these resources to the learning group on the Boost platform, so you can also access them at any time. Again, we're continuing our 2022 Fellow Spotlight series this week with Martha Ngo, who's also our Francophone consultant. She addressed vaccine hesitancy among internally displaced groups in Kumba North and Kumba South districts in the southwest region of Cameroon by training community health workers on immunization. Through her project, hundreds of zero-dose and under-vaccinated children were immunized with the Penta 1, Penta 2, and HPV vaccines. Martha's story, along with several other 2022 fellow stories and case studies, are available to access on our Bright Spots website. And we'll continue to publish more stories and case studies in the next couple weeks. So we do encourage you to check back frequently so you can view those stories and get, again, a better sense of the program and hopefully get inspired for writing your strategic proposals. So for today's session, we, of course, began with some fellowship reminders. I'm going to continue to talk a little bit more about the strategic proposal, which we introduced last week. And then we'll have a larger conversation around vaccine acceptance and demand, which will be led by my WHO colleagues. And again, we'll end the session with Q&A, and then we'll wrap up with a few next steps. So today we're joined by June Ryan Urbina. June has extensive experience improving vaccination demand and uptake through various roles at the World Health Organization. His experience covers strategic and risk communications, community engagement, infodemic management, and developing and implementing evidence-informed strategies and interventions to improve vaccine trust, confidence, and uptake. So before joining the demand and behavioral science teams at WHO headquarters, June was the WHO Philippines vaccine communications focal point from 2015 to 2021, where he supported routine immunization, vaccine introductions and vaccine campaigns, vaccine safety incidents, and the polio outbreak and COVID-19 pandemic response. So we welcome June today. And before June handing it over to you, I do want to just quickly go over some questions that we got from last week. So just take a couple more minutes. So the online submission portal is live as of today. You'll be receiving an email after this session with the link to access it. You will need to create a new account. So this is separate from the account that you created from for the Boost platform, but it really is just your email and a password. So there's not a lot of additional information that you'll have to fill out. But you will be using this account to access the strategic proposal template to draft your proposal. And we do ask that you wait to submit your proposal until the live series is concluded, just to make sure that we've addressed kind of all of your questions and concerns, because once you submit the proposal, you won't be able to resubmit it. We did get some questions last week and in between the live sessions that I did want to address. One important one was, can I submit the proposal as a team? And I know there's been some lively back and forth in the WhatsApp group. So just wanted to acknowledge that I think there are benefits to both the individual and team approach. So we do want to provide options for both. So if you are interested in submitting the proposal as a team, we ask that you work with a team of up to 2 other fellows. So they have to be participating in the program. So a max of 3 fellows per team to submit the strategic proposal. Some very important notes. Again, other fellows have to be registered for this cohort of the COVID-19 Recovery Fellowship. Team members must be from the same country or region. So the purpose of submitting this strategic proposal is to actually implement it. So it has to be with folks that you will be implementing the work with. Proposals will be selected based on content. So team proposals will not have an advantage over individual ones because they'll all be assessed equally based on their content. We do ask that teams or individuals only submit 1 proposal. And if you are submitting as a team, you do need to designate a focal point on your team to submit. And if you are selected, if your team is selected for a mentorship, you'll have to continue with that focal point to liaise with the mentor and the team. You're also welcome to work with other colleagues outside of the fellowship, but your proposals will have to be submitted individually. Again, I think there are benefits to both approaches. We do want to keep the WhatsApp group open for members from all countries and regions because I think there's valuable experiences that are shared there, and some are, you know, across different contexts that you might be able to apply best practices. So we do want to keep that open. If you do want to create separate country or regional groups, you're welcome to do so, but our admin team will not be kind of facilitating or leading those groups. So just want to acknowledge that. And again, if you want to submit individually, we also encourage that as well. A few other questions that we got. Should my proposal be related to COVID-19 vaccination? Your proposal should actually focus on activities relating to improving your immunization program. So focused on COVID-19 recovery. And activities should focus on aspects and areas within the broader routine immunization that suffered the most during the COVID-19 pandemic. So no, not focused on COVID-19 vaccinations, but routine immunization and strengthening those programs post-pandemic. Is it possible to develop the proposal for specific areas or regions instead of an entire country? Yes, and we highly encourage that. Your proposal addresses specific areas or regions to ensure that the approach is best contextualized and feasible, given that it is a short timeline for the project. Countrywide proposals will be considered if there is appropriate support and resources identified in that proposal. And then last but not least, does the proposal need approval from country government, stakeholders, or partners? Not necessarily for the purpose of submitting the proposal. However, we think it would be a good idea to discuss the proposal with your supervisor and relevant stakeholders. Some other important considerations when it comes to filling out your strategic proposal. We do ask that you read each section carefully. We do have important guiding questions and clarifications there. So please do read those instructions very carefully before you fill out each section. We do ask that your responses be supported with data and other resources. All proposals will be reviewed by a committee of peers and experts. And then we'll be selecting about 60 proposals to move on to phase 2, which is the mentorship program. And we'll have some more information on that selection criteria in the coming weeks. And then the deadline to submit the proposal is October 9th. So you'll have a few weeks after the end of the live engagement series to work on your proposals. We're also in the midst of organizing a support session, which will take place following the week of the live engagement series in case you have additional questions or concerns or want to learn from some previous fellows who we'll bring in for that support session. So with that, I want to hand it over to Laura, who's just going to give a very quick recap of last week's session. So over to you, Laura.
Thank you, Liz, and hello, everybody. We're more than halfway through, which is great. So we're just going to do a very quick recap. So next slide. So last week we asked you which aspects of the first two sessions are most relevant to you for recovery of an immunization program? So in the learning group forum, the feedback we got, we have some examples here. So Amanda from Liberia, she was saying that catch-up vaccination, MOV integration are relevant for the recovery of immunization. And I think what she was emphasizing in her response was that having a better understanding of why and reasons why there are people being missed, and also thinking about the gender-related issues could help address some of the main barriers. Evans from Ghana, he said that he found both of the presentations highlighted the need to identify the relevant populations expect to be vaccinated and to plan within the local context to ensure that you don't miss that our populations don't miss routine vaccines. And I think overall, the idea behind the response was to try and ensure that we identify those that are being missed and reach those who are zero dose through different strategies. And finally, Cynthia from Nigeria, she found the integration aspect relevant, particularly related to her work, where she focuses on addressing the needs of women and children in her state, and achieves that believes that having a sustainable vaccination program can greatly promote health through closing the gender gap. And it's very important to have this at every stage of the program. And I think what's interesting is that gender has been mentioned frequently, and I think that's always something, and we have recommended that you think about when you're considering your proposals. And I think just from a general summary of last week, I think the approaches of life course integration, a few years ago, these were kind of a bit vague, I think, for many people, but I sensed last week that there was a really increased understanding and adoption of what those two strategies mean. And I hope that recognizing that the life course approach has a bit more national level decision making, as does integration. But one thing I wanted to mention from last week is that there was a comment about how can we have integration if we don't have national policies. And one thing I wanted to emphasize is that, and the reason why this type of fellowship and having proposals put together, is that we lack a lot of evidence for integration in life course, because things happen, but people don't document it. So I think whatever you think could be possible, I think if you can put it in a proposal, and if we're able to implement it, then hopefully having that as a documented example will be of great help, not only to your other peers, but also showing at national level that this is possible, but also showing others in other countries what is possible also. So with that, I'm going to pass over to June, and wishing you all a great session, and thank you for your attention.
Thank you very much, Liz and Laura, and welcome to our participants to today's session on vaccine demand and uptake. Good morning, good afternoon, or maybe good evening to everyone, and we're delighted that you have joined this third session on vaccination demand and uptake. I understand that this has been sort of become a more prominent field in the past few years. So I'm delighted to facilitate this session and interact and learn from you as well. So for this session, we'll be focusing on two main topics. One is for us to have a better understanding of what drives vaccination uptake. This will allow us to know the reasons for low vaccination uptake and how to address these issues in a more tailored and very contextualized and also an evidence-based manner. For the second part of this presentation, we'll go to a more practical set of skills, which is on having meaningful conversations on vaccination. And this will help us enable to respond to questions and concerns and help increase vaccine confidence. It's a very practical skill that we can use when we interact with parents and caregivers, or even with our peers, or even people in the community. So in our session today, we'll cover quite a range of tools, and we hope that after today's session, you'll be able to have a closer look at these tools. And if you're thinking of doing a project on demand and uptake, I hope that you'll find these tools very useful in your own specific context. So next slide, please. To start with, we know that vaccination programs are faced with a lot of challenges on increasing vaccination uptake. And these challenges are very context specific. They're also very time-bound. They change over time, and they can vary from one vaccine to another. So it's becoming quite a complicated problem. So think of Sarah first. You can think of Sarah as a young mother in your community whose children are not vaccinated. So thinking about her and why her children are not vaccinated, what do you think are reasons for non-vaccination? You can indicate them in the chat. You can reflect on this question based on your own context. So we can have some answers in the chat. So why do you think Sarah's children are not vaccinated in your own specific context? I can see some responses now that Sarah's husband does not allow. There's no access, for example. There could be social, cultural issues. Elliot said that, oh, the chat is going quite fast. So I can see that a lot of us can identify a lot of these different problems. And if we can click to the next, please. You'll see here quite a range of problems that a lot of you have mentioned. For example, Sarah might not be aware of the schedule, or she would have wanted to have her children vaccinated, but then no one would take care of the other kids if she would have her youngest, for example, vaccinated. Or she might be interested in going to the health center, but the waiting area is too crowded, it's too cramped and too hot for her, and she doesn't want to wait. Or maybe she believes that vaccination may cause autism because she saw it on social media. So there are quite a variety of these different reasons and a lot of different challenges which need to be understood. So the question then is, how can we parse through these different challenges and make sense out of them for us to be able to design very targeted strategies, knowing that there are quite a variety of barriers identified? In short, where do we start? So next, please. The simple model, which some of us or some of those who have heard would adhere to, would be that it's because communities or people would hear anti-vaccination messages, their confidence would decrease, and then that would result to low vaccination coverage, and then that would result to outbreaks or risks of outbreaks or outbreaks themselves. That misinformation and rumors caused by bad actors can lead to a decrease in confidence. But this explanation is frequently offered sometimes by people from work, people from the media, for example. But based on evidence and experience, we know that it's much more complicated than this. It's not just straightforward that we just give out information, then that would correct confidence and that would correct the coverage. So the lack of accurate information is just one of the many causes of low coverage. And next, please. And for us to better understand what drives vaccination uptake, WHO in 2018 established a global expert group to look at the different drivers of behavioral and social drivers for vaccination uptake. And you'll see this framework shown before you, which shows 4 different domains that contribute to vaccination uptake. You can see these 4 different domains in this blue square here. One domain is on thinking and feeling, what a particular person thinks cognitively and his or her own feelings on vaccines, his or her own perceived risk, and confidence in and in trust that vaccines work, vaccines are effective, and they are delivered through a trustworthy health system. So that's one domain. Another domain are social processes, social norms such as support of family and leaders, religious leaders, for example. Their interaction also with health workers, are health workers recommending the vaccines? We know that health workers are the trusted, if not among the trusted voices in the community. There may be some gender issues as well. And these contribute to motivation, which is the state of decision-making for a particular individual, whether or not to get vaccinated. And this is where hesitancy can actually come in. We factor in also in this purple square practical issues. So a parent, for example, might be motivated to get the vaccine, but then there are practical issues which serve as barrier. For example, vaccines are not available at the health center. They're not affordable. I would have to pay for access, for example. Or maybe I'm not treated very well by the health worker when I go to the health center. And all these different domains are organized in this framework for us to better understand and have a basis for the development of measurement tools to assess and understand vaccination uptake. Next, please. So for us to better measure and use data in understanding the different barriers for vaccination uptake, WHO has also developed different BEST tools. These are qualitative tools and quantitative tools in the form of surveys validated surveys and validated interview questions. An example is shown here. One quantitative survey tool which has been validated is how easy is it to get vaccination services for your child? Would you say not at all easy, a little easy, moderately easy, very easy? And this is also paired with, if we click please, with qualitative tools, which are for the program manager, health worker, and parent, which are to be used for in-depth interviews. And this would provide us with more background and more narrative on the reasons of the driver in focus for immunization. Next, please. So here's a snapshot of how these tools have been used and demonstrated. This is a snapshot of findings from Nigeria, for example, looking at the 5 priority indicators for childhood vaccination. Best would have, I think, more than 20 indicators, but 5 are priority indicators, and they are shown here as the results. And we can see here that confidence in vaccine benefits are quite high. It's quite high, actually. And there's good intention, high intention to get the child vaccinated. The family is more or less supportive of vaccination as well. But if we look at practical issues such as knowing where to get vaccinated or the affordability of vaccines, these are quite low. And if you look further at the knowledge of where to get vaccinated, you would see here that the results, the difference of results among males and females. And we can see that men are more likely not able to identify where to get their child vaccinated. Next, please. And this is another example from Ethiopia. This was measured, by the way, during around August 2021 at the height of the COVID-19 pandemic, and shows us quite a different scenario, quite different result here, wherein in terms of intentions to get vaccinated or family norms, they could hypothesize that there's sort of a gender issue going on here, with men, for example, in the family having lower intentions of getting the child vaccinated. Affordability also shows here as an issue. And what both of these show, the Nigeria and Ethiopia results show, is that by using these standardized sets of indicators, we're able to compare from one locality to another, one country to another. And at the same time, we're also able to have a fresh perspective on where to focus our efforts on and where to strengthen our interventions, such as when we're faced with that variety of reasons for low uptake, as we have enumerated in Sarah's case, we would know where to focus our efforts on and drive more interventions towards. Next, please. So why is it important for us to measure BEST, or the behavioral and social drivers for immunization? As mentioned, it's important because this will provide us with data to understand and address reasons for low uptake. So our interventions are not just, randomly picked because of the louder voices who would say, oh, let's do a communication campaign, whereas it might be better if we focus our efforts, say, on strengthening, for example, community champions, for example, or improving access to vaccination. BEST also helps guide policy-making, planning, and evaluation, prioritizing resources, for example, and tailoring and evaluating specific interventions. And you can see here on the right how this can take place, wherein we initially diagnose, say, through a baseline survey, what are the different drivers for immunization uptake in a particular locality we're working on, design the interventions, implement them, and evaluate them, again, using the BEST tools. And beyond these, we're able to allocate resources, as mentioned, enhance transparency and ownership, support training programs by enabling us to identify areas where there are gaps, for example, in information, or gaps in skills in terms of interacting with parents and caregivers. It will strengthen also stakeholder engagement, knowing, for example, that we have CSOs working in our communities who can better access the communities that are zero dose, or for example, who have been had low coverage across time. And this will also inform advocacy efforts at all levels. So in short, once we have data-driven interventions, we're able to justify them better on the choice of the intervention, and for us to be able to decide more impactful ones to use in our particular settings or in a particular context. Next, please. So it's not just enough that we have data, but for us to be able to use such data to drive towards action. And the BEST working group also did literature review of various interventions which have been effective and how they relate into the domain on which they are identified. So you would see here in this table the various domains, as mentioned here, the 4 different domains, and the corresponding interventions. So for example, if we're able to identify that a lot of the issues or drivers of low vaccination uptake is on the social processes side, then the likely effective interventions will be community engagement, positive social norm messages, having vaccine champions and advocates, and recommendations to vaccines to vaccinate from health workers. But we have seen, and I know this from your experience, from mine and your own experience as well, that once we address practical issues, this is the strongest motivator actually of behavior towards vaccination. If we make it easier for a parent or caregiver, for example, to access immunization, then they're likely to have more positive behavior of getting their child or getting themselves vaccinated. Note that multi-component interventions are more effective than single interventions. And as mentioned in the previous slide, monitoring and evaluation is always needed. Next, please. We have mentioned the importance of having quality immunization services. Enabling a positive experience of our clients is an important factor important practical factor in improving vaccination uptake. And we have come up with an evidence-informed guide. The link is shown here. It's called the Quality Immunization Services Planning Guide, which provides the different principles and have a think through of what we can implement in our own specific contexts in using data-driven strategies in improving vaccination services. So you can explore more of this in the link provided, and I think the PDF file will also be shared with you in the platform. Next, please. Also, it's important to involve the communities in decision-making for the different interventions, because we know that communities have better knowledge on their own context. They have the solutions, actually. They know the problem and they know the solutions. Sometimes we just need to facilitate them into identifying these solutions, which are already present on hand. And to make this process easy, UNICEF and WHO has come up with this manual called HCD-TIP, which is the Human-Centered Design for Tailoring Immunization Programs. And this is important. This provides important steps for engaging locally with prioritized populations to improve coverage and equity or recovery after events. And you would see here the diagram on how HCD-TIP is an iterative process, starting with small workable solutions and working on the way up and expanding them, and working with the community in the process such that there's community ownership with the intervention and that it's being monitored and also there's community accountability also on how interventions are carried out for immunization, for improving immunization uptake. Next, please. So again, going to Sarah's case, that we had the question of why are Sarah's children not vaccinated? Next, please. We might see from BEST that she may not be aware of the schedule. This might have been information which has been surfaced, for example, in qualitative data analysis, or she didn't like the picture of the pamphlet she received. It was not representative of her. So we know that once we have data on this, then we are directed towards probable interventions that we can work with, like we may need new information materials, or we may need different channels to access Sarah. Next, please. Next, our data might show us that Sarah has religious concerns, or she may not trust national health authorities on their decision-making on vaccines. So this may lead us to specific interventions as well, such as having community champions or working with the religious or faith-based organizations, for example, as being part of immunization teams. Next, please. Or Sarah might feel that she wanted to have her child vaccinated, but she just didn't have the motivation to do it. And one of the reasons is that the opening hours is not convenient and waiting time might be too long. So we might consider revised timing for the sessions, or we may ask mothers such as Sarah what would work for them and do HCD tip and see if such solution would work as well. So what these examples point to us is that once we have data which can drive towards correct interventions, then we could have better outcomes at improving vaccination demand and uptake. Next, please. So this is just to show us that in building and sustaining uptake, it's really a comprehensive approach, looking at the individual level and trying to shape confidence and motivation for that individual to get vaccinated. But at the same time, realizing that we don't exist in a vacuum. An individual lives with a community, has a family around him, has friends and networks. And then such is also present within a health system, for example, and also that exists within the context of institutional policies. So what we would need, as shown here, is really to look at different interventions across different levels, such that we're able to sustain demand and confidence, build demand and confidence, and sustain it at an individual level, and looking at the broader community as well. So I'll pause here and have a look at some of the questions and see if we can answer one or two before we proceed to the next part of this session. So one of the questions here is, why clients hesitating vaccines for outbreak response, and which communication mechanism would be effective? This is by Mersha Gorfu. So thanks, Mersha, for this question. So again, this is a very this question is a lot of layers and could be interpreted in various ways. The question is why and which communication mechanism would be effective. I would say that it's really important for us to be able to dissect the problem, because each context would be different and one size doesn't fit all. For example, hesitancy might come from previous trauma, for example, with vaccine-related events. There might be a vaccine-related event in the past wherein people are more sensitive to vaccine safety issues. Then this may need a different kind of communications approach. And when we're thinking of communications approach, it may not be health workers themselves. There might be some other more trusted individuals in the community. It might be your religious leaders, for example. It might be your local doctor, who's not involved in the public health system, for example. Or hesitancy may not be driven by information itself at all, but may be held back, for example, by social processes or social beliefs, such as, say, there's unclear stance, for example, of the religious network on whether or not their constituents need to be vaccinated or not. So what we're trying to say here is that it's really important for us to dissect the problem and understand the problem in its different facets. And only then can we be able to identify which the whys, which is shown by the best itself, and then which particular channels would be most effective. But this is a very important question and brings to mind also a lot of experiences we've had in the past in responding to these kinds of problems. So I'll proceed now to the next part of the session, and we'll go now to a more specific and more practical aspect on how to have meaningful conversations about vaccination. So next, please. So why is it important for us to have meaningful conversations on vaccination? Meaningful conversations help build trust and in vaccines and health services. And people wouldn't listen to, or maybe wouldn't follow with positive behaviors from people whom they don't trust. So it's really important to have a trusted relationship, and it starts with having empathy and being able to express that through meaningful conversations. So it's important to make people feel heard and understood, because I understand most of us coming from the technical field, there's really that urge, or there's really that desire to put out information and to correct wrong information right away. And that sometimes could just shut down a person and makes the person feel unheard and understood, and he or she will not be able to listen whatever crucial information or advice you'd be giving later on. It will also enable people's concerns to be surfaced and addressed because we allow the conversation to progress rather than us being prescriptive and stopping the conversation at our own prescriptions. Ushering people to information and services in a respectful manner, helping people connect with their own motivations for vaccinating, and facilitating a positive health experience, as we have shown earlier in having quality health service experiences. So meaningful conversations are important between the health worker and the parent or caregiver, or even among us, among our peers, among our networks, people that we speak with, because these small conversations, when we use techniques to help move the person from being hesitant towards accepting the vaccines, this creates ripple effects and enables us to collectively build trust towards vaccination. Next, please. So intentions towards vaccination actually span a spectrum. So if we think about the vaccine conversation we've recently had with someone, we can think of where that person sits on the spectrum. A lot of the people probably we interact with are very accepting. They would say, yes, let's go with being vaccinated today. They may have some questions or may not know where to get vaccinated, but their motivation, their decision to get vaccinated is really a check mark right at the offset. There might be some on the yellow part of the bar here where they may be hesitant. They may still have some questions that they would like to resolve. They may delay vaccination, for example, or accept vaccines, some vaccines accept and not accept other vaccines. And in the past few years, I can sense that vaccine hesitant, the term vaccine hesitant has had a negative connotation already. It has sort of become a negative label where in essence, it's just a person asking, actually. It's a person having questions about vaccines. And when we see it that way, there's really that opportunity of driving the desires of that person towards being accepting of vaccines and moving away from being hesitant. There's also the set of people who are declining. They would say outrightly that vaccination is not the right choice for me. They haven't had vaccinated themselves or their children since they were born, for example. And not within these different categories are the anti-vaxxers, who are a really small set of people who would outrightly refuse vaccines and probably spread anti-vaccination messages. So when we encounter someone, it's important to see where they sit in this spectrum and understand that we have different communication goals depending on where they sit on the spectrum. Next, please. Next. So for example, if a person is accepting, our goal really is to answer questions, to clarify whatever questions they have on vaccination, remind them about their vaccination schedule and eligibility, direct them to vaccination services if they're not aware where to access vaccination within their specific areas, and also consider warning them about circulating misinformation, inoculating, for example, such information that, oh, you might be able to read that some groups are circulating so-and-so fake news about vaccines. Know that vaccines are safe. These have been tested and carefully monitored by our regulators, and the vaccines that we are giving as part of our health services are safe for you and your children. Next. There might be some who might be hesitant, and our goals are to increase vaccine confidence, to increase their belief that vaccines are safe and delivered by a trustworthy health system, to address their concerns, to direct them to reliable information sources if you don't have such information readily available with you, and to encourage vaccination and help them access the clinic. And for those who are declining, next please, it's important that we have to know that our goal is not to argue, not to make enemies. It's really to raise awareness of not vaccinating, to maintain trust and engagement, knowing that we may not be able to convince or motivate a person with just one conversation. It might be a series of conversation over time. So it's important really to maintain such trust, and that you'll have a second chance to speak with this person again. Avoid debate, and if possible, keep the discussion brief. Next, please. So we're offering here several tips, 3 main tips and 3 sub-tips for each of the main tip for you to consider in conversing with someone who is unsure or someone who sits on that spectrum where he or she is hesitant. First is to listen with empathy. And doing so, we're able to find out their concerns or questions. So empathy really starts with active listening. As mentioned, let's avoid the righting reflex. It's really the urge to instantly correct, to fix, or to prescribe solutions. We can also express empathy through our body language, like nodding, pausing, for example, expressing that you're able to hear and understand, and listen with empathy to their questions and concerns, and ask open-ended questions. Questions such as, what questions do you have? Why do you feel that way? This stimulates conversation than having just close-ended questions which require yes or no answers. Acknowledge them and their experiences. If we do the righting reflex, as mentioned, this really shuts down their own experiences and invalidates them. So we can say it's okay to have questions. It's okay to be concerned with your child's safety. And if you want more information about vaccine, that's perfectly normal. So saying sentences such as this establishes empathy and establishes also that you're here to listen and acknowledge them and their experiences. Next, please. Second, if there's an opportunity, why not get personal? Share your story. If you previously had concerns you worked through and ended up getting vaccinated or your child vaccinated, share what helped reassure you. For example, I had similar questions before on the safety of this new vaccine to my child. But when I heard from a health worker several information, then I became more confident with the vaccine. Is it all right with you that I share this information? So if you share your story, that means that there is something which that person is able to anchor to and you're able to relate with each other well. Explore also reasons for wanting to get vaccinated and encourage and recommend vaccination. So in your conversations, some hooks might be present where you can explore possible reasons for wanting to get vaccinated. For example, oh, I heard that your child was able to get the BCG at birth dose, but wasn't able to get the succeeding doses. Why is it so? Then the parent might be able to respond, oh, I was concerned with my child getting TB. That's why I ensured that he or she had the vaccine. So you can use that as a hook and try to express also motivation, encourage motivation into getting vaccines for other antigens or other vaccine preventable diseases. Next, please. Third is to share knowledge and offer help. And this is an important conversation tip because we're able to hopefully replace whatever wrong information is present, wrong knowledge is there. If you share trusted information, or maybe allow them to explore where to find information which can challenge what they have in mind as well. And if we offer help, offer practical help within our own capacity, of course, it also serves a nudge wherein it makes the behavior of getting your child vaccinated or getting yourself vaccinated much easier. So our aim here is to really make vaccination as an easy behavior to do. Next, please. Okay, so we can arrange all these different tips in this card, actually, which can look like a bingo card. In other sessions, we play this as a bingo game wherein we can listen to a conversation and tick off the different tips as they are expressed in a role play, for example. But unfortunately, in the interest of time, we could not do them here. But this is something where you can do in a gamified manner in your own communities, for example, or among health workers you work with, or even among peers. You can role play vaccine conversation, or in one, maybe his hesitant one is, another is an advocate for vaccines, and see how the conversation goes and how these tips are being used. But just as a taster, let's proceed to a few slides. Next, please. So identify the conversation tip. As demonstrated here, you can list them down in the chat. For example, parent is saying, I'm a bit worried about the vaccine. Then health worker or maybe someone from the community would say, I hear you. It's okay to have questions or need more information. So what kind of tip is this among the 9 tips shown? You can write them down on the chat. Yeah, so while we wait for answers, we can proceed to the next slide. So for the previous slide, it's really about acknowledging them and their experiences. Here, a person says, the parent or caregiver says, I heard vaccines have side effects. Then the response from the health workers, I was also concerned about side effects when I had my child vaccinated, but I was relieved that they were mild and manageable. So this is an example of sharing your story. And the third example, the parent says, I'd like to have my child vaccinated, but I have to inform my husband first because he decides for the family. Then the caregiver, the health worker says, sure, you can help. You can drop by anytime later for your child's vaccines. You can call the health center's number anytime if you need help. So this is an example of offering practical help within your own capacity, which, as we've mentioned, nudges the person into the behavior of getting vaccinated or getting his or her child vaccinated much easier. Next, please. So in summary, we've shown you different tools, and you can access these tools, for example, the tools and guidance on behavioral and social drivers on vaccination on the links shown here. And you would see here the guide itself for BEST. Plus, there are a lot of supporting tools such as ODK forms, analysis frameworks, code books, questionnaires, interview guides, which you can download from this link as well and use in your own specific communities as you use data, as you gather and use data for more effective interventions. Next, please. And this link down here on the slide will lead you to the various resources which we've explained earlier, the position paper on BEST, plus the tools on BEST, the planning guide and quality immunization services, human-centered design for tailoring immunization programs, the HCD tip in working with communities. And we also have the quick tips guide for helping people get vaccinated, which is very adaptable tool for community engagement. So you can access all the guidance on this link shown here. Next, please. So again, the vaccination demand and uptake, as I mentioned, has been a growing field, and it's really an important field to consider, knowing that we can't just have enough supply and expect communities to demand for vaccines. There are a variety of different other factors which come into play, as shown by the behavioral and social drivers of immunization. And our role here is really to make the best use of these tools such that we're able to address the different and address and tailor the different situations, different contexts in our specific communities, and really move towards in improving vaccination uptake, particularly in high-risk communities and high-risk scenarios. So thank you very much. And we have a bit more time for Q&As. So.
Super. June, thank you so much. That was really, really comprehensive and lovely flow to how you delivered all the different aspects related to this topic that is very interesting, and you can see that many people have questions. So there are a couple of questions in the chat that I would like to put to you. So one question, which I think is probably one that you hear quite a lot. So David Abbas has asked, what can be done about the proliferation of disinformation and misinformation on social and mainstream media about vaccines?
It's really a recognized problem now. So even at WHO, we have the infodemic management team, which has the expertise to look specifically on this. And there are a lot of ways where we can look at addressing the issue of infodemics, particularly for vaccines. One is really looking at strengthening the confidence of our communities and of people on understanding what vaccines are and being able to navigate and have the skills for identifying what is fake and what is not, what is to be shared and what's not. So we can look at two different ways of addressing this here. Looking at information and knowledge needs to settle what issues of safety there is among the communities. And second is providing them with the health literacy skills to be able to identify what's correct and what's not. On the other hand, there's also the role of the different influencers, different voices around us, to be able to manage misinformation and disinformation. So there really has to be strong alternative voices which need to counter these. Sometimes they're very anti-vaccination voices are sometimes working in silos, so they tend to be louder. But if we have, for example, unified voices with people within the health system and outside the health system, for example, religious leaders or community leaders, for example, other cause-oriented groups saying all together how vaccines are safe and effective, and this can drown out the small voices of the anti-vaccination move. On a more institutional level, the government, the community can look at different policies, of course, to see how information can be controlled across social media and across how they are shared. And we've seen how this has taken place with, for example, with Facebook or even with Twitter on how certain news have been flagged. So again, going back to that model we've shown earlier on building and sustaining trust, wherein an individual exists in a context of a family, a society, a system, and the institutions, we can look at different interventions at solving the issue, the growing issue of infodemics through this framework.
Great, thank you. And I know that there has been a lot of work done about infodemics, particularly over the past couple of 2-3 years, because of a lot of misinformation, not just about vaccines, but general health and COVID-19. So it's a very relevant question. Another question that I think is very relevant. So it's from Mofisara Omobwale, who wants to know where data systems are not optimal. How can behavioral science help? I think it's a really great question.
I'm sorry, can you come again? I'm trying to look at it.
Where data systems are not strong, how can behavioral science help?
Okay, so behavioral science is still really important. We've shown you the best, which is a set of standardized tools, which can be used in a more formal way and standardized way within an existing data system. But at the same time, BEST is also very flexible for use in situations or in contexts where there is not a very strong data collection system, for example. What we just have to note is that, for example, if we're doing convenience sampling, knowing the extent by which we interpret the information we have. But what's important to take note here is that for our interventions to really be impactful in the communities that we serve, social data is needed. And social data needs to inform the interventions that we carry out. Whether these social data is collected by a broad tool and a very specific tool like BEST, or maybe parts of BEST, or maybe some other tool which you can find useful. Or this may be anecdotal reports of using other methods of, say, observing how a community does its daily life. These are all important and needs to be put together for us to be able to tailor and really understand the problem and address it in a specific way. So to answer your question, behavioral science has a space in problem solving, whether it's in a system where there is sophisticated data management or in more simpler systems.
Great, thank you. And there's a question from Tanvir Hossain, who is, I think, awaiting your response. But can the BESD tool be used to see the behavioral and social drivers of an individual vaccine before its introduction? So before you introduce a new vaccine, can the tool be used?
Yes, the tool is very important as for this particular purpose as well. As mentioned, it can be used as a tool to measure baseline behavioral and social drivers. And that would be very interesting in terms of informing how to improve uptake of a vaccine which is about to be introduced, and say measuring after vaccine introduction how such domains, for example, have changed, how confidence has changed, for example, or how gender influences have changed after vaccine introduction. And that can tell you that your interventions that you have put in place before vaccine introduction in order to increase vaccine uptake have indeed worked. So it's important to be used before in terms of having a baseline and also in terms of monitoring as well if your interventions have been impactful.
Great. And I think, I don't know how much, we'll try one or two more questions, but Melanie Abongo asks, how would you handle religion as an inhibiting factor for vaccine uptake?
Religion is a very sensitive topic, as I would understand, and some of the issues on low vaccination uptake, which is driven by religious reasons, has been there for quite a long time, and just these have been perennial problems and just been resurfacing time and again. But we have seen positive results on polio campaigns, for example, working with Islamic leaders, and for them to be able to come together and have a voice and really support vaccination among their communities. So there are bright spots that can be done by engaging religious leaders. And I think what's important here is for us to be able to encourage also coordination among faith-based groups, because once they are coordinated and once they have one voice towards a certain issue, in this case vaccination, then such voice becomes even more trusted by the community, and this may allow certain behaviors to change as well. I know it's much easier said than done. Advocacy for vaccine acceptance, for example, for particular religious groups, in terms of advocacy to their leadership across different levels, it's quite a difficult undertaking. But we've seen in previous experience that it's doable, albeit a bit recognizably difficult pathway to take.
Great. And one final question, and it's from Annette Kisake in Uganda. So Annette wants to know, one other group that needs BESD are the health workers. Have you conducted some work in this group?
I'm sorry, can you come again?
One other group that needs BESD are the health workers, and has work been done in this group amongst health workers?
Yes. Actually, when you look at the best tools, you would see their surveys, and at the same time qualitative in-depth interview tools. And among in-depth interview tools, you can see that there are in-depth interview tools for parents and caregivers, for health workers, for program managers, and for community leaders. So health workers are really part of the entire equation, because we understand as well that sometimes health workers would have the hesitancy as well towards vaccines, and these need to be understood and addressed. At the same time that that community behaviors towards vaccination would need to be addressed as well. So BEST offers these different tools for both caregivers and health workers and other actors on vaccination.
Thank you so much, June, and thank you everyone for the questions. There are many more, so if there is time, we will try and respond to those individually. So over to you, Liz, for the closing out of the session.
Great. Thanks so much, Laura, and thanks so much, June, for such a great presentation and addressing so many questions. And like Laura said, we have additional forums through the Boost Learning group. So if you have additional questions or comments, please feel free to share them there. And speaking of the Boost Learning group, we do have a reflection question for you, which we'll post in the forum. So we're asking, what will you do differently now to better understand and address low uptake? Kind of based on what you learned in the session today and what you've reflected on, please do share your comments in the Boost Learning group forum. We've shared a link in the chat, and again, we'll share this link in the post-session email that will go out tomorrow. And then next week's session, the final session in the live engagement series, will be on reducing zero-dose children. And again, we do ask that you please take our post-session survey, which will pop up when you exit the session today. Again, we have the Boost Learning group and WhatsApp group forums. I know we got many questions today about joining the WhatsApp group. You will need to click on that link from your phone, from your mobile device. So if you're trying to click on it from a computer, you can download the WhatsApp desktop version to your computer. But if you'd rather do that on your phone and you don't have an opportunity at this moment, again, we'll share that link afterwards. So we just ask that you click on it on your phone. You will need to download WhatsApp if you don't have WhatsApp on your phone to use that. Again, we do have the Boost Learning Group, and we have the emails that will go out. So there are other ways to connect with both facilitators and peers. So appreciate your patience. We also do need to approve the requests that go through. So we do try to do that within a minute or two. But we do thank you in advance again for your patience. And again, if you've attended all of the live engagements, or if you've watched the recording and filled out the post-session survey, you will receive a certificate of completion for the series. You'll also have to submit your strategic proposal, again, either individually or as a team, to receive that certificate of completion. If you do have any other questions or concerns, you can always email us at info@boostcommunity.org. Again, just want to thank our facilitators today and thank all of our participants for your engagement and your questions and comments. We appreciate that, and again, encourage you to continue the conversation in between sessions through the Boost Learning platform and the WhatsApp groups. Until next week, thank you and enjoy the rest of your day.